of all, thank you for the kind invitation, and you know, it's my almost second home, Singapore, since I came, and I have very nice, memories about staying in Singapore. So thank you again. Besazo, it was introduced by Adrian. It's a particular. It's not a meeting like 7 minutes presentation, no questions, but it's similar to the teaching at university. So because of that, I'm used to ask also to people that it's attending and listening, because it's important for me to understand if I'm clear in some points or not. So expecting from me some question to you. First of all, my disclosure, and you see that I'm actually working with many companies on imaging, so you can see different types of instruments here, but also I will be a little bit cold in the presentation of angiography, because I think it's a multimodality imaging approach. It's quite important. So it's not just something in the multi-imaging support. Now, how many of you are using an angiography right now? Can you? Yes. So not so many. So I will try to explain. So this is the angiography. And actually, just to understand, it's the algorithm that changed the OCT, angio from the normal OCT, from what we are used to work with. And of course, I don't understand anything from that. But the things that I understood was that you have 2 time points, time 1 and time 2. And anything is moving in the vessels is giving an image if it's acquired in time 1 and time 2. There is also the possibility that the things inside the vessel are too fast. So in time 1 and time 2 you don't get an image. So at the end you don't get an image. Or it can be also the opposite, where you have time 1 is grabbing an image, but it's too slow to get an image in time 2, so you don't have an image. So remember that it's only what it's moving at a certain speed you will acquire, not anything. The other interesting thing is that you are taking an image, still frame image, of something that moves. It's like seeing in fluorescent angiography or an ICG in mid-phase, where your artery and veins are filled. So the problem is that here, and this is a angio OCT B scan, and what is white is the things that are moving. And now, which is the artery, which is the vein? You don't know. You know which is the artery and which is the vein. Get an image, looks similar, so it's impossible just based on angiocts deciding which is the artery and which is the vein. The image presented before on some paper that was showing the artery and veins are actually identified in fluorescent angiography or in looking at color and looking at the size, and then going back to the angiocts, because you don't know, you don't see the film, you just get a still frame image. The other thing is that you don't get, first of all, when we speak about OCT angiography, we actually, as Michel told us before, a series of instruments. And this makes a little bit more difficult, because when we speak about fluorescent angiography or ICG, we probably consider 2 possibilities. the fundus camera, the regular fundus camera, and the scanning laser. Now here we actually have different things. The first angiography was introduced by a group from Caltech University, from the Scott Fraser group, and was using the phase variance. So taking the information from the phase of the image. Then Ricky Wong at the Washington University take the amplitude and the phase, and they create the optical microangiography that is used, the technology that is used by Zeiss for the angioplex. The same things, phase and amplitude, is used by Nidec, and they call complex. Then we know about the OptoView, that was the first commercial available instrument. They developed their split spectrum amplitude decorrelation angiography that is actually using only the amplitude. Then we have the Heidelberg and Canon that use also the amplitude, but not split spectrum, but the full spectrum. And then we have Topcon that is using a subsource, not a spectral domain, like the others, and is using also a full spectrum ratio-based. And then last but not least, the Amsterdam University developed an instrument to measure the flow. They were not able to actually measure probably very well the flow in the Doppler effect, but they got a very nice OCT, angiography images. So many different approaches, and also some differences in visualizing the retina. So these are the superficial and the deep, and you see that there are some little differences in the normal subjects. And if we go deeper in the choroid, in the level of the choroid capillary, you see also that there is some differences. Remember that the only available in the market are the SADA and the angioplex. The complex, so the Nidec and the SADA, that is the Heidelberg, are still in the development. So it's not probably the final things, but right now are not exactly the same appearance. And for another choroidal vascularization, you see the three different, the same lesion seen with three different modalities. The other interesting thing is that when we speak about, as I told you, we have, yes, a case of occlusion of the vessels, and you see, sorry, I'm just only one second. I change the size and it's completely different. So you see, this is a occlusion, artery and veins, and you see that there is also a new retinal vessel over here. Now, if you look in color, you see that it appears almost completely white, probably some flow inside. If you do a fluorescein and you overlap, you see that there is no filling at least. You actually see leakage from a new retinal vessel, but the occluded vessels, it seems that it doesn't have any flow. Now, if we overlap the angiocytes, we actually see blood inside, and there is some movement. The problem is that the size of the vessel is not the anatomical size of the vessels. It's just the lumen of the vessel that we visualize. And in this case, it's extreme, so we actually see the difference between the vessel when we look at the color or fluorescence or any reflective image, and the angiocytes, where we actually visualize only the area where something is moving inside. So, for example, and I will go, if we want to look at some regression of vessels only with angiocts, probably this is not correct, because we actually see if it's perfused or not. And if the lesion is not perfused, it doesn't mean that it's reduced in size and you know, anatomical structure. What about artifacts? From people who's using the OCTA this as normal image, taken probably in not the last you know, software, but one of the first. And when you get an image, you can get such artifacts. And what are these artifacts? Are just the movement of the eye. And any movement, of course, the instrument is considered something, vessels or anything. And so you have such an image. The OCTA is acquiring horizontal and vertical, and then the software is aligning and you know, eliminating all these lines. But you have also this the prototype from Heidelberg, and you see that there are also some artifacts there. And this actually is not moving. They have you know, a tracking system, so they actually acquire only the eye stable, and that can take a longer time. You know, just to give an idea, if a normal subject with a good fixation can be acquired in 4 seconds, or around 4 seconds per, a little bit less for you know, any horizontal and vertical. With the Heidelberg, it can take 3 minutes right now. So it's quite a different things. But you see, there is some artifacts there, and if you look, it's only the fact that it's the segmentation was not correct. So there are series of artifacts. Of course, everything will be solved in the future, but right now you have to consider all these things. And then you can actually have the same thing that you have with a normal OCT. So for example, here the patient is blinking, and you can actually get a line, a black line instead of a white line that you see, or the shadowing due to the anything in the vitreous that allows not to realize, not to penetrate. And you see that case, it looks like a macro hole, but it's actually not only macro hole, it's anything. Just looking at the other effect is the projection artifact. And the projection artifact, we will see, it's quite interesting because we can actually use to identify some structure. So for example, here is the retinal vessel going back. You see one of the retinal vessel, here is one. And you see that the retinal vessel is also visible here and here. And then at the level of any fiber layer, it disappeared and then reappear a little bit deeper. Why that? Why you don't see there? You know, if I have something that projects with the lights, of course, it will go and it appears deeper. It should be visible also for all the structure. Why is missing one part? Anyone can think about? Why I don't see here? You see, the white part. I apologize for projection because it's a little bit more less evident and not on my screen. But you see here it's white. Then you have an area where you don't see the vessel, and then it reappears. Why this projection effect is not visible here? Okay, so sorry.
think due to the RPE reflective light better than.
Do you have yes.
I think
So just for a second, so everybody can.
I think due to the RPE, the ability reflect light better than other retinal structure.
Well, here, this is by the way, this is a B angio scan, so it's not a normal OCT scan. But the eye is perfectly intact. It's a normal eye, and there is something, of course, here the RP is here. So these are at the level of the photoreceptors. And but again, why this is not visible? So the light is coming, all of a sudden disappear, and then at the level of an fiber layer, and then reappear. I can try to show you something else. In choroidal neovascularization, the same things. If you explode it, you actually see this actually a normal OCT, but the red is in optobule, you actually see a sample. So you see that you have some projection effect also here from choroidal neovascularization. But if you look at the vessels there, you see that all of a sudden the red things here is not evident. And then it's reappear over here. You see? So going back to the normal visualization of the normal OCT, and remember that any image of the OCT angio is coming from the same light. So what you see in the reflective OCT, you will see also in the angiocytes. And you see that the end fiber layer is dark. But, and we actually don't see in a normal OCT the end fiber layer and the outer nuclear layer. It looks exactly the same. But if we move a little bit, and the light is not coming straight, but straight on the end fiber layer, you see that reappear. And so just tilting, you get the visualization of the OCT. Now, since the projection effect is just a reflecting light, since you don't have a reflection here, it's going through, is not reflected. So this is why you have lights that all of a sudden at the level of the end fiber layer are not visible because it's not reflected, and then it's coming back and it's reflected. Okay, thanks. So this is another patient that was treated, was diagnosed as an inflammatory CMV. And the CMVs on the angiography was considered 1, 2, and 3. Okay? Now, I will show you the OCT, but in particular, all the imaging modalities. And just to show, these two things, here you actually see something at the level of the OCT, or normal OCT, and then the autofluorescence and fluorescing and ICG and fluorescing. And just to know where the cut was taken. And you see one thing quite interesting, that of course these are not choroidal neovascularization, but it's just lack of RP cells. And the lack of RP cells are seen in the autofluorescence. Now, why we see white and it looks like a net, a choroidal net? Because if you look at here in the OCTs, you see that there is some transmission of the light. It means that there is no RP, but the photoreceptor is still there. There is no RP. The choriocapillary is normal, so you actually have a window to the choriocapillary, and this is why you actually see quite nice, like a net, your lesion, but in fact, it's a normal choriocapillary seen better because there is no RP that is masked. So it's dangerous to see just one type of imaging. And you see, just adding the autofluorescence, you were able to better understand what was those two little round shape, quite nice net, but in fact was a normal pillar. And if you want to look at the other artifacts, in this paper by Rick Spade, James Fujimoto, and Nadia Rahid, it's very, very nice, and you can actually get all the other things. What we have to keep in mind when we look at angiocts: different segmentation layers, different speed, and the absence of filling. Now, just to go to a different segmentation, this is a patient, and just look at how small is the changes here of the segmentation, and the image of the choroidal vascularization can be visible or not, depending just little movement of our segmentation slab. But just to summarize, if you look 1, 2, and 3, and you, for example, take this image, and then you go back, and you say, wow, the treatment was very effective, but in fact, it's just moving a little bit your slab. And so, as we were used to do with a normal cube, with a normal OCT, that we have to look at all the B-scan, here we actually have to see all the slab, because the lesion can change in the location just because there is no fluid after the treatment, and the lesion is going down, and so you don't see anymore, but in fact it's still evident, but just change the location. So pay attention, don't evaluate only based on your angio OCT and fast, but look where the slab was taken first, and then consider the fact that you have to take more than one slab to understand if really the lesion is appearing. And also, there is another issue that was also underlined before, that depending on your slab, you can change completely the appearance of the lesion. You see, we just move, this was stable, and we actually just increase the size, the thickness of the slab. And the same with the optoglyph, the same things. Just adding more confounding projection effect or less, you can actually see more or less the lesion. But you see that the segmentation, it was always starting at the same point, but was changing just the thickness of the slab. And of course, if you change also the type of the segmentation, you can get also a different image of the same lesion. Now, if we look at different layers, you see that the lesion that was evident in the outer layer here in yellow is also evident in red. So it's a thick lesion that is going from one place to another, or what else? And if you look to this case, you see here, we think the lesion is located. So you actually expect to see the lesion at the level of just over the RPE, but it's not visible in your angiographies. And just moving down, all the lesions come out. And most of the time, the best image is the one that you get from the projection, artifact or projection effect. That's so don't stay at one position. Just move, and you will get probably a better from different speed. Nice branch vein occlusion, and you see that if we overlap our angiography, it's perfect. It's exactly the same things. Now, if we put side by side, of course, we actually see some differences. For example, this macroaneurysm are not visible here. However, this one is evident there. And also, look at these vessels. It's not present there. And why? Probably due to the fact that in macroaneurysm or this vessel, the flow is too slow, and so you don't get any image. So remember that not all the microaneurysms are visible, not all the layers are visible. Of course, if we want to measure the not perfused area, it's easier with angiographies because you have high contrast. If you do a fluorescein, here it's a confocal, first of all, then you have a very early phases, so you don't have leakage. And for automatic measurement done by any software, of course, with black and white, it's easier than not in grayscale to play with, to identify all the non-perfused areas. So the angiography is very useful for that. It will help us to measure, and the software is already present. And you saw before from my colleague previous presentations where it was visible that the OCTA is already able to measure. But remember that something can be missed. And here, very nice macroaneurysm, clear, fluorescent, in color, but not in angiography. For the same reason, the flow is too slow, so you don't get the image. Or in case of choroidal neovascularization, if you look at this polypoidal, you see the filling is very slow. So if you overlap to this nice polyps here, your angiographies, you see that the polyps by itself is dark. It's not visible. You see over the net, and tomorrow you will listen much more on this topic. But just to remember that the flow is important for identifying structure in with angiographies. Also, the absence of filling. Going back to this image, it's a still frame image taken from something that moves, and so the artery and veins are not identified. So if we have a coronal vascularization like this one, and we do the movie, we can actually see the filling of a feeder vessel and the draining vessels. Now, of course, when we compare an angiography, of course not with a fluorescein, but with an ICG, the appearance of the lesion is quite the same. Unfortunately, we don't know which is the artery and which is the vein. Probably nobody right now is using, the feeder vessel treatment as a principal approach to this type of choroidal vascularization. But, sometimes it could be interesting to know. And again, this is a patient where we treat with a double treatment. But there is a new treatment. It's called Fovista. It's anti-PDGF. And the idea of the anti-PDGF is that since it's acting on the endothelial cells, the lesion should decrease in size and disappear in some way. So this is a patient that was treated, and you see that, of course, this is the best visualization using the right slab. And there is some reduction, but I don't know if this reduction is due to the fact that it's not just perfused, so the vessel is not perfused, or actually it's really reduced as a structure. So, because as I showed before, we see if something is filling or not. So we don't know if the structure is really reduced. So in conclusion, OCT angiography is a new imaging tool, but still we are in the learning curve for better understanding what we see. And I don't know if you know the Fun Club. It's a European club, but it's going around Europe, and it's a case presentation. So every time that it's one day, and from usually from 9:30 to 5 p.m. there is people that presenting cases, a big discussion. It's a lot of fun. So if you have any chance, I will organize on February and at the University of Milan. This site. It is also a nice place to visit, just because it's an historical monument for us. Okay, thanks. Any questions? Please.
Thank you, Giovanni. It's very interesting. Nowadays, the images are being sent to us for readings. Just would like to learn from you whether would it be ideal that the readers be the one reading at the center, or is it still okay to send the images for us to read, like through to the iPad? Because as you mentioned earlier, there are so many artifacts that can happen, and the readers can easily misinterpret all these things. What would be your opinion on that? Because in our place, we usually send images for the consultants to read on.
I actually answer to your question with an example. I don't know if you know that the anti-VEGF is considered, anti-VEGF treatment is considered the cause of geographic atrophy. This is coming from a clinical trial, a series of clinical trials, and unfortunately, it's probably related to the misinterpretation of some image. We know that RAP lesion is connected with the reticular absolute lesion, but also geographic atrophy is connected to reticular absolute lesion. If you look at the numbers, it's overlap. Now, in clinical trials, the readers are obliged to read one imaging modality. So the OCT, the fluorescein, or the fundus color. Sometimes there is also ICG, rare. Now, if you want to read and say there is this feature or this feature, it's fine. But if you want to use as a diagnostic tool you cannot read only one imaging modality. And in fact, we actually had this different approach for some clinical trials. And there is a new drug, it was a phase 2 study, and one of who wrote the protocol on purpose didn't want to have a RAP lesion in the study because he was afraid of the possibility of geographic atrophy, and so he was aware of a problem, and so he said, I don't want to have a RAP lesion. The patient, because of that, was all, the imaging was decided by a reading center. Now, in the 3-arm of the study, just reading then the images, not just like we did the reading center, one by one, but all together, come out that one arm has 20% of RAP, the other 10, and the other 5. Now you can understand that then if the atrophy was coming out from one of the arm because of geographic atrophy or because of the RAP lesion and the correlation with the geographic atrophy, you can actually see that one drug was giving the 20% and one 5%. Wow! So big difference. The problem is that you cannot, as you say, you cannot read for diagnostic purpose only one imaging modalities. And tomorrow I will try to underline even more this idea. I hope I answered to your question.
Follow-up question. Is the company going to develop a software like the CT scan where when we send the images, they can interpret in other computer, the PC for the reading, like diagnostic, where we can read the moving parts of the OCTA?
Do you mean all the, a kind of a 3D reconstruction?
The segmentation, the flow.
Yeah. I think it would be very nice. The problem is that it's not so easy because for many reasons. One, it's the quantity of information is quite huge. Second is that you still have the artifacts. And putting all together is not so easy, at least what they told me, to get rid for all the layers of your projection artifact. So probably in the future will be possible, but right now it's not so easy to get. But I agree, it would be perfect, the best way to isolate all the 3D of the coronal vascularization, and then you actually would be able to see if something really changed in the lesion.
Dr. Saragi, I think you showed us some very nice examples of how if you adjust the segmentation slabs, you can see very different images and the dangers and pitfalls of this. Do you have any advice as to how to adjust this? So what level do we adjust it? Are we still learning that?
I'm actually still learning. I can tell you that when we had the first OptoView machine with the new software, there were no fixed segmentation. And so we actually were spending hours to get the right one. We improved a lot when OptoView decided to put some fixed segmentation. And that, I think, is a good approach. Then you can change a little bit, but maintaining the fixed segmentation, I think, is the easiest way to interpret the images. So, not so, you saw that if we increase the thickness, we actually start to get more artifacts. And of course, it's the lesion, you have a retinal pigment epithelium detachment or a thick lesion, of course you can increase your thickness. But maintaining the ones that it's decided, by the software, I think it's a good approach.
Thank you, Prof, for the answer. I would like to ask a question. If a patient, let's say, patient is going for retinal surgery for VNT and there is a thick postural hyaloid, and if I would like to see if there's macular ischemia, right? So, you know, we can tell a little bit about prognosis to the patient, right? Would we be able to capture a good retinal vasculature picture with this OCT A? And there's thick postural hyaloid, you know, covering the macula and something like that.
Anything that is masking the light, it's creating a problem. So that you can actually get, on the paper by Rick's paper is a very nice example of a thick hyaloid that is giving the idea that you have a pitfalls, but in fact it's just due to the fact that that area it's a shadowing from the thick membrane, I would say. So remember, any image that you get with an angiography is the same, is using the same light that you use with a reflective OCT. So if there is some problem for getting a nice image with a reflective, you will get problem also with the angiography.
Thank you very much.
Are there any other questions for Dr. Storani? Behind you.
I just wanted to ask a slide to show that if you the CAP and then if you deepen out the slab and then the lesions come like prominent. So which one is the real?
Oh, the real.
The real,
Right.
the
I think the real is the ones that show the best image. Now, it's not real the location, but if you want to visualize the lesion, I think that is the real one. So you get all, you know, the lesion, the appearance of the lesion, using the projection effect. Usually it's working like that. It's rare that you get from the anatomical position that you expect. It's sampling with less quality, but not with the projection effect.
And does it apply to another picture in OCTA? Like the picture that we see is the projection artifacts?
Well, in particular for the choroidal lesion, because why you get such a things? Because you discharge some projection effect of the upper layer. So you get a best image because you have less confounding from the other layer.
And in some picture, if you cut the slab in the superficial, very superficial, and then in the vascular zone, you can see the white dot coming up. Like, is that the artifact?
Let me go back so we can actually
I
see.
just saw in some picture, like previous from Dr.
I have let me see. This one, for example.
And so there is no flow in
Here,
the
these
vascular
little
zone, but
things.
sometimes you're going to see the white dot.
Yeah, and that is actually, of course, an artifact. And it could be, it's not clear. You see, for example, if you use the Heidelberg, it's even more evident. But it can be just a contrast effect. So it's not only the image, but also how you play with the image. And for example, Heidelberg has a different series of contrast, and of course, the signal is low, you get more noise, and that probably is just a noise of the image.
If you increase the segment to identify the lesion, when you come for follow-up, will the software remember your choice, or you need to manually?
Yeah. At least with OptoView, you can actually, and I think also for with eyes, you can actually save your slab. The problem is that the lesion can change. And changing the location of the lesion, you can actually miss, even if you were at the same position. So you can, but it's always better to move and sample all the layers.
Okay, are there any other questions?
In terms of masking, alright, I'm wondering if the retina is very thickened due to fluid, for example, like in diabetic edema, or in cases of AMD whereby there's urine, like perfusing material after would it affect the structure that we see?
I can answer the same way that I answered before. You know, if you have an OCT reflective image where hard exudate, for example, is masking, edema by itself is not masking. So the difficulties for diabetic macular edema or any macular edema is that the layers can change before and after treatment. So you can probably not be able to imaging exactly the same layer. But for the penetrating of the light, there is no problem with edema. You have problem with hard exudates. Anything that masks a normal OCT reflective image. Sorry, from this one and this one.
Yeah, the black zone, like the lower 1/3.
This one.
Well, the second one, the complex, and the
complex,
yeah. And then you can see that the picture of the superficial plexus in the lower half, like lower 1/3. Like
this
part,
zone. Yeah, that is actually can be uneven exposition. So if you're not perfectly aligned, you can get such a thing. So
I thought it's because the lines can start from the top to the bottom, and maybe the patient gets the eyes getting dry.
It could be. I confess that I don't know if it's related to that. It could be just because of the fact that the quality of the B scan here is not the same, as good as the initial part. So you can actually have some movements, or taking more time because these are the complex. The NIDEC has a tracking system like the Heidelberg. It can take also 3 minutes. So you have to think that it could be, you're right, it can be just the quality of the image deteriorated by not perfect corneal surface, but it can be just due to the fact that the patient are not able to maintain, and so it takes more time, and the quality is decreasing. But I think your hypothesis can be evaluated in 2 seconds. Just putting some eye drops during the longer position, and you will see if it's improving or not.
Are there any other questions? This is a very good and lively session, I'm sure. If not, maybe we can move on to the next talk by Dr. Rangi, and there'll be time for questions again after that.